ẹ jọ mo fẹ́ kẹ́ sáré confam kan náà ẹ lọ sí TikTok.
TikTok likes. 15 MB.
Ó possible mo kàn fẹ́ confam pé mo fẹ́ confam pé ok mo fẹ́ confam pé ẹni torí mi ì rí lọ́dọ̀ mi bíbí. All right, good evening everyone. Welcome to our live session. Today we'll be discussing in details the osteology of the upper limb. So we have our 3D models ready. We have two models of the skeletal system. Actually, what I did is I tried to uncheck all our other systems so that the response will be a bit faster. We have two models. This is actually a low resolution model, but is a bit faster. The response is faster. This is more detailed, more anatomically accurate, but the response is a bit, as we can see, is lagging. So we'll be switching between the two models depending on what we want to talk about. So the upper limb in human is a freely mobile limb. So the upper limb is freely mobile. It helps to, the reason why it's freely mobile is unlike other animals whose forelimbs are majorly designed for movement, the human upper limb is designed to modify tools, to manipulate tools, and in order to increase our range of activities. So during evolution, we've adapted our upper limbs in order to modify tools, not only for motion or for support, but generally to reach objects and to be able to manipulate different tools. And we can see from if we look at the lower limb, for example, we can see the bones are generally bigger. If we compare, this is the femur, the tibia, and the fibula. If we compare the femur, for example, to the humerus, which is the longest bone in the upper limb, we can see there is a difference in the size. The humerus is smaller and of course less strong than the femur, because the upper limb is designed for wider range of motions, for dexterity rather than for strength. So there are 32 bones in total in the upper limb. We start from the clavicle. So we'll start from the clavicle. Then from the clavicle we'll move to the scapula. From the scapula we'll talk about the humerus. From the humerus we'll talk about the bones in the forearm, that is the radius and the ulna. Then from there we'll talk about the carpal bones, those are the bones that make up the wrist. So let me try to focus on them. We have 8 of them in total. So we have the scaphoid, the lunate, the triquetrum, the pisiform. So then we have the trapezium, the trapezoid, the capitate, the hamate. Then we have the 5 metacarpals, which make up the bone of the palm, and the phalanges, which make up the bone of the fingers. So let's dive into this osteology, and it's going to be an interesting and educative one. Alright, so the first bone we'll talk about will be the clavicle. So this is the clavicle. If we go to the top, so if we see from the, if we look at the overhead view from the top, so we can see this is the clavicle. The outline of the clavicle is roughly S-shaped. I hope you can see my cursor. So the outline of the clavicle is roughly S-shaped. We can see I'm tracing the shape of the clavicle. It's roughly S-shaped. If we go to the high resolution image from here, we can see it is roughly S-shaped. So this is the S-shaped. I'm tracing it. It is concave anteriorly in the lateral 1/3, as we can see here, and it is convex anteriorly in the medial 2/3. So we can see concave in the lateral 1/3, convex anteriorly in the medial 2/3. And basically that's how we can divide the clavicle. The clavicle can be divided into the lateral 1/3, the middle 1/3, and the medial 1/3. So functionally, that's the way we divide the clavicle. We have the medial 1/3, the middle 1/3, and the lateral 1/3. The medial 1/3 and the middle 1/3, they are roughly spherical in cross section. So if we bring out the clavicle from here, so let me move it away from its natural position. So this is the clavicle. If we zoom in on that, we can see it's roughly spherical. If we look at it from the medial end, we can see it's tracing roughly a circular cross section. But if we look at it from the lateral aspect, we can see that it's flattened laterally. So basically the medial 2/3 of the clavicle is roughly spherical in cross section, but the lateral 1/3 is spherical. The upper surface, as you can see, if we look at it from the top, the upper surface is majorly smooth. Then the inferior surface, if we look at it from below, we can see there are some ridges, some tuberosities, and some projections, because at this medial point it comes in contact with the first rib. So if we bring it back to the neutral position or the anatomical position, we can see at this medial end is in contact with the first rib. So there's a groove for that. And also on the lateral aspect, if we look at the inferior surface of the lateral 1/3, there's a projection here, a tuberosity. So there's a ligament that moves from this knuckle-like projection that we'll still talk about from the scapula to this tuberosity of the clavicle, known as the coracoclavicular ligament. Also, there are some grooves underneath for the subclavian vessels as they move across the ribs into the axilla. So the under surface of the clavicle is roughened for many of these ligament attachments and vessels. So generally the clavicle is the bone that connects the rest of the upper limb to the axial skeleton. If we remember very well, roughly we can divide the skeletal system into two. So we can divide it into two. The central system, known as the axial skeleton, that is the skull, the vertebrae, the ribs, the sternum, and the pectoralis, the pectoral girdle. Then we have the limbs, the upper limb that we'll talk about today, and the lower limb. So those are the division of the skeletal system. Now the clavicle connects the upper limb to the axial skeleton, and it does that at a joint that is known as the sternoclavicular joint. If we see, so this highlighted area of the sternum, this highlighted area is known as the manubrium of the sternum. So this area is known as the manubrium of the sternum. So it is connected to the clavicle at what is known as the sternoclavicular joint. This tiny joint over here is a synovial joint. So that joint is the bony attachment for the upper limb to the axial skeleton. So there are a lot of ligaments that support that joint. We have some ligaments from this manubrium of the sternum to the clavicle, also known as sternoclavicular ligament. So there's one anteriorly, there's one superiorly, and there are also some muscles that helps to connect the upper limb to the axial skeleton. So we're mentioning them briefly, but in our upcoming videos about the muscular system, we'll talk about many of those muscles. For example, there's a big muscle in our chest, the pecs, the pectoralis major. So it attaches to the clavicle at this area. It attaches to the sternum and also to the costal cartilages. If we follow the tracing of my cursor, so it attaches to the clavicle, to the sternum, and then to the costal cartilages. Then that big muscle goes on to insert on the humerus. So those muscles sort of provide indirect attachment of the upper limb to the axial skeleton. But the major bony attachment of the upper limb to the axial skeleton is majorly at this tiny joint, the sternoclavicular joint. That's the major bony attachment of the upper limb to the axial skeleton. So laterally, the clavicle attaches to the scapula. So this bone that I just highlighted now is known as the scapula. This bone is the scapula. So it attaches to the clavicle at the acromioclavicular joint. The reason is this bony structure, this bony projection of the scapula here at my cursor is known as the acromion. So this connects to the clavicle, and also the scapula also connects to the humerus. So we have the clavicle sort of bridging the gap between the scapula and the axial skeleton. Basically, that's what it does. It connects the upper limb to the axial skeleton. It provides attachment points for some big muscles, and it increases the range of motion of the upper limb. That is the sort of the summary of the function of the clavicle. That's basically what it does. It is the first bone actually in the body that started ossification. It begins ossification in utero, that is when we're still babies. And funnily enough, it is also the last to complete its ossification. It does so at about 21 years of age. The clavicle is a long bone. By classification or by definition, it is categorized as a long bone. Also, another fact about the clavicle is it is the only long bone in the body that lies horizontally. All the other long bones in the body, if we zoom out to the full skeletal system, we can see the humerus is a long bone, the radius, the ulna, those are long bones, but they lie vertically in the body, unlike the clavicle, which sort of lies horizontally, but at the same time it is still categorized as a long bone. So basically that's the summary. Then in terms of muscle attachment, at the medial end of the clavicle, there's a muscle that attaches here, comes from the temple region and attaches to the medial end of the clavicle. The muscle is known as the sternocleidomastoid muscle, which is not shown here, but we'll talk about those muscles in our upcoming videos. So this part of the skull, this area of the skull, this bone is known as the temporal bone. So there's a projection. Let me zoom in on the projection here. The projection here is known as the mastoid process. So the muscle attaches to the mastoid process, then runs across the neck like this. It traces like this, then attaches to the medial end of the clavicle and the sternum. Hence, it is known as the sternocleidomastoid muscle. That is from the sternum, from the clavicle, then to the mastoid process. So, so this surface, the upper surface, the superior surface on the medial aspect, gives attachment points to the sternocleidomastoid muscle. Then posteriorly, the lateral 1/3 gives attachment points to the trapezius muscle, which we'll still discuss about later. Then anteriorly, the lateral 1/3 gives attachment points to the deltoid muscle. But on the medial 2/3, anterior surface gives attachment point to the pectoralis major muscle. So we talked about pectoralis major muscle the other time. So the pectoralis major muscle originates from the anterior surface of the medial 2/3 of the clavicle, while the lateral 1/3 on the anterior surface gives attachment points to the deltoid muscle. Then posteriorly, the lateral 1/3 gives attachment point to the trapezius muscle, also called the traps, which is also called the traps. So basically, that summarizes the clavicle. If we have any question, we could put it down in our chats. We would like to answer many of them in the chat session. So if we have any question about some of these bones, we can put it there. So I will surely be reading the chat once in a while. So from the clavicle, we can move on to the next bone, which happens to be the scapula. So if we look at it from the posterior surface, so let me zoom in on the bone. So let me zoom in on. So this is the right scapula, this is the left scapula. So I've highlighted the right scapula for us to see. So as we can see the scapula, we can feel it. If you touch your the upper aspect of your back, you can feel the bone, because this spine, this little projection here, also called the spine, which we talk about later, can be felt under our skin. So it can be felt just underneath our skin. So this muscle, this bone, if we look at it very well, we can see it traces a triangular pattern. Let me go to the lower resolution image just to quickly outline the shape. So this is the clavicle. This is the scapula over here. So if we look at it from the posterior surface, we can see it traces a roughly triangular section. So we can see a triangle actually has three sides, just as you know. A triangle has three sides, has three angles. So we can see there is this side, which is called the medial side or the medial border. So we call it medial border. So this is the medial border of the scapula. The second side over here is known as the lateral border. That's the lateral side. Then superiorly, we have the superior border. So those are the three sides. You know, we said the scapula is roughly triangular in cross section. So we have the medial border of the scapula, the lateral border of the scapula, and the superior border of the scapula. Also, just as we know, a triangle also has three angles apart from three sides. A angle is, by definition, junction between two lines. So where two borders meet, we call that the angle. For example, if we trace the medial border, if you can follow my cursor over here, so the medial border of the scapula, where it's joined with the lateral border of the scapula, is known as the inferior angle of the scapula. So this is the inferior angle of the scapula. The junction between the medial border and the superior border is known as the superior angle. So this little bony projection here, so this is the superior angle of the scapula. Then where the lateral border meets with the superior border is known as the lateral angle of the scapula. But if we go and view it from the lateral side, we can see a lot of bony projections from the lateral angle. In fact, the lateral angle of the scapula has been modified into a cavity. So we can see this shallow cavity over here. So this is known as the glenoid cavity. So the lateral angle of the scapula has been modified into the glenoid cavity, and it is the point of attachment to the humerus. So let me bring it back to its neutral position, or the anatomical position. We can see, so this is the scapula and this is the humerus. So the humerus attaches to the scapula at the glenoid cavity, which is why the shoulder joint is also called the glenohumeral joint. The glenoid cavity with the humerus, so we call it the glenohumeral joint. So let's go back to our detailed 3D model. So I'm going to bring it out a bit so that we can talk about some of the projections and the structure of the scapula. So I'm trying to bring it to where we can view it very well in terms of light. So we can see, so just as we've mentioned, this is the roughly triangular shape, the inferior angle over here, the superior angle over here, and the lateral angle. So it has two surfaces. We are looking at it from the back, that is the posterior surface. So the posterior surface of the scapula, if we go from the medial side, we can see this ridge, this projection that divides it into unequal halves. This projection here moving like this. So this projection traces both to the side, that is laterally, and upward. So we can see this ridge, it moves laterally and upward. This is known as the spine of the scapula. So this is the spine of the scapula. If you touch your back, that's what you normally feel. So the spine of the scapula, it divides the posterior surface into two unequal fossa or fossae. So we have the supraspinatus, because this is the spine. So the fossa above the spine is known as the supraspinous fossa. So we can see from here. So this is the supraspinous fossa, and it is the point of origin for the supraspinatus muscle. So this spine divides the posterior surface into two. The supraspinous fossa, which is the point of origin for the supraspinatus muscle. Then we have the infraspinous fossa below the spine. So the infraspinous fossa, it is the point of origin of the infraspinatus muscle, and the spine, just like we mentioned, traces upward and laterally, and at its lateral end it becomes the acromion. So if we move into the lateral end, as you can see, it becomes the acromion. So this is the acromion of the scapula. So the acromion of the scapula is the free lateral end of the spine of the scapula. So this acromion is what articulates with the clavicle, just like we mentioned the other time. So we can see in this low resolution model, so this is the acromion and this is the clavicle. So it is the acromion of the scapula that attaches to the clavicle, Now if we trace the superior border, so this line, this is the medial border. Now this is the superior angle. So we can see, actually I'm not done with the labelings of some of these parts, but as you can see, the superior angle of the scapula have been labeled. So if we trace the superior angle and we trace it laterally, we can see a notch, a depression here. So this depression is what is known as the scapular notch. It is what is known as the scapular notch. After the scapular notch, the superior border becomes modified into a knuckle-like projection. We can see this projection looks like a knuckle. If you look at your thumb, so this thing looks exactly like a thumb. So this knuckle-like projection is known as the coracoid process of the scapula. So this is known as the coracoid process of the scapula. So the superior border of the scapula from the medial side traces, then becomes a notch, the scapular notch, then becomes the coracoid process. In the body, there's a ligament that covers this notch. It bridges this notch over here. So this is known as the transverse scapular ligament. So it is known as the transverse scapular ligament. And the suprascapular nerve actually passes through that foramen. This is a notch. So the ligament converts the notch into a foramen, an opening, and the suprascapular nerve actually passes through the opening to supply the supraspinatus muscle and the infraspinatus muscle. So lateral to the scapular notch, we have the coracoid process. So let me center the scapula. So this is the coracoid process of the scapula. The coracoid process also provides attachment points for multiple muscles. So this is the, so if we look at it in the anatomical position, this is the coracoid process. So it provides attachment points for the coracobrachialis muscle, from the name, the coracoid process, up to the arm, because the arm is known as brachial in anatomical term. So the coracobrachialis muscle actually originates from this. Also, the short head of biceps brachii also originates from the coracoid process of the scapula. And also another small muscle in the chest known as the pectoralis minor muscle, which originates from the ribs here, also converges to this coracoid process, the pectoralis minor. And if you remember, as a slight deviation, as the axillary vessels passes through the axilla, it is the pectoralis minor muscle here which divides it into three parts: the first, second, and the third part. So that's the coracoid process of the scapula. So that's the coracoid process of the scapula. Then we've talked about the glenoid cavity. So if we go back to our image, so the lateral angle has been modified into the glenoid cavity. So we can see this whitish color. I've used it to represent the hyaline cartilage of each joint. So this whitish discoloration we can see are the hyaline cartilage of the shoulder joint. So this is the glenoid cavity. Above the glenoid cavity, we have the supraglenoid tubercle, and below we have the infraglenoid tubercle. So the supraglenoid tubercle is the point of origin for the long head of biceps. So the long head of biceps originates from here, the supraglenoid tubercle, while the short head of biceps originates from here, the coracoid process, while the infraglenoid tubercle is the point of origin for the long head of triceps brachii, for the long head of triceps brachii. And on the anterior surface of the scapula, we can see a depression here. This is known as the subscapular fossa of the scapula, subscapular fossa, and is the point of origin for the subscapularis muscle. So it is the point of attachment or point of origin of the subscapularis muscle. So basically that's a summarized version of the osteology of the scapula, Of course, if we have any question, we can put it down in the chat section, so we can answer some of the questions that we have, so that we can answer some of them. All right, so let me bring the scapula back to the anatomical position. Now, as a clinical correlate, the clavicle can actually fracture, especially during childbirth. So when a child is being delivered, and when the child is being delivered in malpresentation, breech delivery, so the clavicle can be fractured, and in young children the clavicle can bend in what is known as a green stick fracture. So a green stick fracture is not a complete break of bone. So there's one of our videos where we talk about the classification of fractures. If you can remember, there's the compound fracture, simple fracture, open fracture, closed fracture. There's the green stick fracture where the bone sort of bends instead of breaking completely. So the clavicle can also fracture, although in younger children most commonly green stick fracture. But even if the clavicle breaks completely, it most often happens in the medial one, in the middle 1/3. So the lateral 1/3 and the medial 1/3 they are not susceptible to fracture, but the middle 1/3 of the clavicle breaks or fractures commonly. The reason is because there are important ligaments that attaches to the clavicle, both the coracoclavicular, costoclavicular ligaments, and those ligaments in themselves, they are stronger than the clavicle. So if the clavicle wants to fracture, most commonly it happens in the middle 1/3 or the middle portion of the clavicle, and this fractured end can actually damage the axillary or the subclavius. So because they pass under the clavicle here, so they are known as the subclavius or subclavian vessels before it becomes the axillary vessel. So fracture of the clavicle can actually damage those vessels. So we've concluded the osteology of the clavicle and the scapula. So now let's talk about the osteology of the humerus. So the humerus happens to be the longest bone in the upper limb. So it is the longest bone in the upper limb. So of course it's a long bone, and unlike the clavicle, which lies horizontally, the clavicle lies, we can see it lies vertically in the arm. So we can see it extends from the shoulder joint over here. I hope you can still follow my cursor. So over here to the elbow. So this portion is known as the arm. Of course, in layman's term, all the upper limb can be referred to as the arm, but anatomically speaking, the arm is the region between the shoulder and the elbow. So that is known as the arm. So the region between the elbow and the wrist, so if you go to a low resolution image, is known as the forearm. So the region from the shoulder to the elbow is known as the arm. So the region from the elbow to the wrist is what is known as the forearm. It's known as the forearm. So the humerus is the bone of the arm. It is the bony framework of the arm, and it is the longest bone in the upper limb. It is the longest bone in the upper limb. So it is roughly cylindrical in cross section, and it has three parts. It can be broken down into three main regions. We have the proximal segment, we have the middle portion, and then we have the distal segment. Also, just as I mentioned the other time, if you have any question, you can actually type it in the comment section so that we'll attend to them, and just try to answer some of the questions that we have, so we can attend to any questions we have. All right, so the humerus, just as we've mentioned, has three sections: the proximal portion, the middle portion, and the distal portion. So the proximal portion, we have the head. So just like most long bones, so we can see, so this here is the head of the humerus. So let me bring it out from its anatomical position so we can rotate around the humerus freely. So we can see, if we look from the medial aspect, we can see this spherical portion that is covered by hyaline cartilage. So that is known as the head of the humerus. So we can see this shiny portion that I'm that I'm highlighting now. So this is the head of the humerus. We can see that it's covered with hyaline cartilage because it articulates with the glenoid cavity of the scapula at the glenohumeral joint. However, this head, which is spherical, or let's say 1/4 of a sphere anyway, because it's not completely spherical, is much more bigger than the glenoid cavity. So we can see it is much more bigger. In fact, the head of the humerus is 4 times as big as the glenoid cavity. So the glenoid cavity doesn't accommodate the head of the humerus completely. Unlike the hip joint, if you try to look at the hip joint, we can see that the head of the femur fits into the acetabulum of the hip bone almost completely. So we can see it fits deeply into the acetabulum of the hip bone. So that is why the hip bone is much more stable than the shoulder joint. So the upper limb or the shoulder joint is sacrificing stability for mobility. So because of this, the shoulder joint can dislocate more commonly. It can dislocate more commonly than the hip joint, but it is freely mobile. So we have a wide range of motion in our shoulder. So we can abduct, that is move it to the side. We can rotate, we can flex, we can extend. That's why we can bring our hand and touch the opposite ear, passing through raising the arm over our head. So we can reach so many objects from our position. We can use it to manipulate tools, manipulate objects. So most of those functions is actually as a result of the function of this shoulder joint. And it comes down to this because the glenoid cavity is much more shallower than the head of the humerus. So at this rim, at the rim of the glenoid cavity, there is a tissue, we call it the labrum, the glenoid labrum. So it's sort of a fibrocartilaginous tissue, like a ligament. So the labrum is what attaches to the head of the humerus, and it does so at a point that is known as the anatomical neck. So if we go back to our humerus, we can see where the head it ends here. So we can see I'm tracing the junction of the head and the other part of the humerus. So we can see this region. So that is known as the anatomical neck of the humerus. So we can see here is the anatomical neck. So it is the point at which the glenoid labrum actually attaches to the humerus. So in the resting phase, if we go to let's go to our low resolution image. So we can see that at rest or in the anatomical position, the glenoid cavity actually binds or attaches more to the inferior and anterior portion of the head of the humerus. If we see from the back, we can see that the posterior surface is free, and also most of the superior surface is also free. So at rest, the glenoid cavity attaches to the anterior and inferior portion of the head of the humerus. So the humerus can abduct, it can move to the side, and it can rotate inwardly as much as possible. It can rotate as much as possible without any problem. Also, if we look at the bony framework here, now there are some important ligaments and muscles that stabilize the head of the humerus in the shoulder joint. So we have what is known as the rotator cuff muscle, which we'll still talk about. Then we can see this bony structure, which, if we remember, is the acromion of the scapula. So this is the acromion of the scapula. Now the acromion, so if there's a force trying to move this humerus up, we can see that there's going to be restriction or limitation here. But if we move it inferiorly, we can see there is no much restriction here. It is one of the reasons why the shoulder joint dislocates more commonly in the inferior direction. In fact, the most common dislocation of the shoulder happens inferiorly and anteriorly. So it happens antero-inferiorly, like this. So most of the dislocation of the shoulder joint happens like this. It dislocates inferiorly and anteriorly in this direction. So apart from this bony structure, it is because the ligaments that also supports the shoulder joint, they are weakest in the inferior and in the anterior direction. So let's bring it back to its anatomical position. So if we go back to our high resolution image, so we've talked about the anatomical neck of the humerus. So that's because it is the junction of the articulating surface with the rest of the body. So anatomically speaking, that is the neck of the humerus. But there's a surgical neck of the humerus, which is an important site for fracture, which we'll talk about. Because before we get to the surgical neck, we have two projections just after the anatomical neck. So we have two important projections, which is called the tubercles of the humerus. It is called the tubercles of the humerus, also known as the tuberosity of the humerus. So let me bring it down back to its anatomical position so we can see. So this is one of the projection, and it is smaller than this projection. So this is known as the lesser tubercle or the lesser tuberosity, while this more prominent one is known as the greater tubercle or the greater tuberosity. So the lesser tubercle or the lesser tuberosity, we can see, if we look at it from the side, we can see that the lesser tubercle is facing anteriorly, is projecting forward. So we can see, I'm looking at it from the side now. So let's bring it to the center. So we can see the lesser tubercle is projecting forward. So this is the lesser tubercle. So it's projecting forward, while the lesser tubercle is facing us in the lateral direction. So the greater tubercle projects laterally, while the lesser tubercle or the lesser tuberosity faces more forward. And in between, so we can see that in between, so let me hide this labeling since it's disturbing our view. So in between the two, we can see, so this is the greater tubercle, this is the lesser tubercle. We can see that in between we have a depression, a groove, more like a valley in between two mountains. So we have the lesser tubercle, the greater tubercle, then a valley in between. So this is known as a groove or a sulcus. So the name of the sulcus is the intertubercular sulcus, in between the tubercles. So the intertubercular sulcus, also known as the bicipital groove. It was formerly known as the bicipital groove because, if you remember, we said the long head of biceps originate from here. This point that I'm highlighting, that's the supraglenoid tubercle. So it moves across the head and anatomical neck, then passes through this groove. Hence it is called the bicipital groove, because the long head of biceps actually passes through this valley. Hence it is known as the bicipital groove. But now it is more commonly or more correctly referred to as the intertubercular sulcus. Now the tuberosities of most bones, what they do is that they increase the surface area of the bones for muscle attachment. So anywhere you see tuberosity, just know there is a ligament or a muscle, or muscles or ligament anyway attaching to that area. So the same thing goes for the humerus here. So the greater tubercle here, or the greater tuberosity, provides attachment points for the supraspinatus muscle. Remember, the supraspinatus muscle comes from the supraspinous fossa here. So it passes like this, then attaches here. So the supraspinatus attaches here. The infraspinatus, which moves from the infraspinous fossa, also attaches there, just below the supraspinatus. Then there's a muscle we call the teres minor muscle. So the teres minor muscle also originates from the lateral border of the scapula over here, and it also inserts on the greater tubercle of the humerus. So the greater tubercle provides attachment points for the supraspinatus, the infraspinatus, and the teres minor muscle. While on the lesser tubercle, the subscapularis muscle, as it is moving from this subscapularis fossa, attaches here. Those four muscles together, they are known as the rotator cuff muscle. So I've released a short video on the rotator cuff muscle. So I show the muscles and the attachment and the origin. So the subscapularis here, which moves like this, the supraspinatus, which moves like that, the infraspinatus, and the teres minor muscle. So those four muscles, they are known as the rotator cuff muscle, and they are part of the muscles that stabilize the head of the humerus in the glenoid cavity. So they stabilize the head of the humerus in the glenoid cavity. So sometimes there could be injury to those four muscles, also called rotator cuff injury. So it can lead to pain, tenderness, and even issues with the shoulder joint. So with the shoulder joint. So this is a low resolution image showing the head of the scapula. So we've talked about the tuberosities or the tubercles of the humerus. Now, just below the tuberosity, we can see that the proximal portion becomes narrow. So it becomes narrow. So this narrow portion, let me show the labelings again. So this narrow portion here is known as the surgical neck of the humerus. It is surgical neck of the humerus because, surgically speaking, it's a very important landmark, because it is one of the areas of the humerus that fractures easily. So now the tubercles or the tuberosities can also fracture, but the fractures here most often result as a result of direct trauma to the humerus, as a result of direct trauma to the head of the to the proximal portion of the humerus. But if there is a fall, especially in elderly patients, the bones of elderly patients are more often weak than that of or weaker than that of younger individuals. So if there is an indirect trauma, or if there is a fall, then there is usually fracture of the surgical neck of the humerus. And this surgical neck of the humerus, the axillary nerve also winds around this place posteriorly. So the axillary nerve passes through this place. There's a small space here, they call it the quadrangular space. So we'll be talking about all those ones later in upcoming videos. So the axillary nerve actually passes through here. So if there's a fracture at the surgical neck, there could be injury to the axillary nerve. There could be injury to the axillary nerve. So that's the surgical neck of the humerus. Also, after the tuberosity, there are some crests. So the crest here, it provides attachment point for some muscles too. So in the floor in between the crest, we have the latissimus dorsi. Then on the lateral side, we have the pectoralis major. And on the medial side, we have the teres major. Remember, we talked about the pectoralis major. So the pectoralis major inserts here. It originates from here, the medial 2/3 of clavicle, the sternum, and the costal cartilage, then converges at this point. Then the teres major, which comes from the inferior angle of the scapula, comes like this and attaches here on the medial crest, or the crest of the lesser tubercle. And in between, we have the latissimus dorsi. So there's a funny mnemonic we use in medicine. We can say a lady sitting in between two majors. So we have the pectoralis major, we have the teres major, then we have the lady, that's the latissimus dorsi. So sitting in between the two majors. So that concludes our osteology of the proximal section of the humerus. Then from there, we'll go to the shaft of the humerus. So in the shaft of the humerus, basically it's cylindrical in cross section. So let me remove the labeling. So just distal to the tubercle, so we have the shaft of the humerus. The shaft of the humerus basically doesn't have many landmarks, but we'll talk about two of them now. So on the lateral surface, if we trace, we can see this is the greater tubercle. We can see the crest moving downward. So the crest at the middle portion becomes this projection, a tuberosity. And I mentioned the other time, I said anytime we hear tuberosity, we should know that muscles or ligaments must have attached to the place, because that's the work of a tuberosity. It increases the surface area of the bone for muscle or ligament attachment. So the crest of the greater tubercle becomes modified here into a tuberosity, which is known as the deltoid tuberosity. So on the lateral, remember, the greater tubercle is facing us laterally. We are looking at the bone now from the side, from the lateral aspect. So the crest becomes modified into the tuberosity is the insertion point for the deltoid muscle. Remember the deltoid muscle coming from here, the anterior surface of the lateral 1/3 of the clavicle, the acromion, and also the posterior surface of the spine of scapula. Let's go to the lower resolution image. So the deltoid originates from here, the lateral 1/3 of the clavicle on the anterior aspect, the acromion, and also the posterior surface of the spine of scapula. So from there it attaches to the deltoid tuberosity. The deltoid muscle is a big muscle actually. It's the site of injection for most of the intramuscular muscles of the upper limb. Most injections they are given into the deltoid muscle. So that's the deltoid tuberosity on the shaft. Then on the posterior aspect, there's a groove called the radial groove. So there's a groove known as the radial groove. It might not be very prominent in this bony structure, but if we can see this groove here, so there's a groove here. It is known as the radial groove. So like this. So that is the radial groove. So what passes through the radial groove is the radial nerve and the deep branch of the brachial artery, also called the profunda brachii artery. So they passes through, and because this mid portion or the mid shaft can also fracture easily, especially when we fall on our outstretched arm, so there could be injury, because the fragment of bones that are broken can actually damage both the nerve and the vessel. So there could be damage to the radial nerve at this region if there is a fracture of the shaft of the humerus, and also it can also damage the radial nerve. So basically that's the middle portion of the humerus. And then on the distal portion of the humerus, we can see there are some interesting bony landmarks there. So let's look at it from the front. Okay, so we can see, so this is the distal portion of the humerus. So from this area to this place, so we can see this selected area that I'm highlighting in this box. So that's the distal portion of the humerus, and we can see some interesting bony landmarks or structure there. So we start from this line over here. So this is known as the supracondylar ridges. Supracondylar ridges. So we can see there's the medial and there's the lateral supracondylar ridges. So in between these supracondylar ridges, there is the point of origin of a muscle that is known as the brachioradialis muscle, or sort of the brachialis muscle. The brachialis muscle. So it originates from here, the brachialis muscle. Then so just after the, now we can see two bony landmarks here that have been covered with hyaline cartilages. You can see one on the lateral side, one on the medial side. The one on the lateral side is known as the capitulum. It's called the capitulum. So this rounded fragment. So let me try to separate the humerus from the ulna and radius so that we can see. So let me bring it out so that we can focus on it without trying to separate it from the ulna and radius, so we can see. Or let me bring it back to its anatomical position and hide the ulna and radius. Let's just bring it out a bit. I think that might be better for us. Okay, so we can see, so this is the capitulum. So this rounded structure is the capitulum, while the medial articulating surface is known as the trochlea. Now these two together, they are known as the condyles of the humerus. So just above that, we have the epicondyles. So we have the condyles, which has been modified into the capitulum and the trochlea. Then just above that, we have the epicondyle. We have the lateral epicondyle and the medial epicondyle. So the medial epicondyle is more prominent than the lateral epicondyle. So you can see the medial epicondyle. We can feel the medial epicondyle. If we touch the inner aspect of our elbow, we can feel this bone here. So this is the medial epicondyle. The ulnar nerve actually passes just behind this medial epicondyle. So the ulnar nerve passes behind this medial epicondyle. Then we have the lateral epicondyle of the humerus. Then we have the supracondylar ridges, just like we've mentioned. Now, there are three important foci around the elbow joint, or around the distal aspect of the humerus. So if we zoom in on that very well, so we can see one above the trochlea. So the one above the trochlea is known as the coronoid fossa. So we can see this area, which is a bit deep, coronoid fossa, and it provides insertion points for this projection on the ulna. So this projection on the ulna that I'm highlighting now, this is known as the coronoid process. Now, not to be confused with the coracoid process of the scapula. The coracoid process is found on the scapula, but the coronoid process is found on the ulna. So the coronoid process of the ulna fits into the humerus during elbow flexion. So when we flex our elbow, this bone rotates. So this process fits into the coronoid fossa. Then there's a shallow fossa just above the capitulum. So that shallow fossa is known as the radial fossa. So you can see this is the radius. There are no prominent projection on the head of the radius. So the radial fossa here is shallower compared to the coronoid fossa. Now, if we go to the back of the humerus, we can see a very deep projection here, a very deep fossa here. So this is known as the olecranon fossa. So it accommodates this process, the olecranon process of the ulna. So this process is accommodated by the olecranon fossa. So if I bring this back to the anatomical position, we can see the olecranon process of the ulna fits into the olecranon fossa during elbow extension. So let me bring it down a bit. Then from the posterior aspect, we can see that the capitulum, let's go to the anterior side. So this is the capitulum, this is the trochlea. If we look at it from the posterior aspect, we can see that the capitulum is not visible, but the trochlea is visible. Another thing which we can notice is that the trochlea has the medial end. This is the medial end. The medial end of the trochlea projects inferiorly. It projects inferiorly. So like this. So this is responsible for something known as the carrying angle of the elbow joint. If we go to our lower resolution image from here and I zoom out, we can see if we try to draw a straight line from the shoulder, if we draw a straight line from the shoulder down to the elbow, and we try to, now if we draw a straight line, there's a deviation because this elbow joint moves slightly away the carrying angle, this angle here. So if you draw a line from this humerus down to here, that's known as the, so if we are trying to compare the two image, so let's move to the front. If we try to compare these two image or these two models, we can see that the carrying angle demonstrated in this framework is not as, is more than the carrying angle of the elbow in males. And what is responsible for that is this little projection of the trochlea of the humerus. So the projection of the trochlea of the humerus. So if we go to the posterior side, we can also see just as I mentioned the other time. So there's a groove just behind the posterior or the medial epicondyle. So there's a funny sensation you are going to feel in your forearm. So that's why it is called so you can have that funny feeling, because at that point you can. So that basically concludes our osteology of the humerus. So we'll go now to the osteology of the ulna and that of the radius. We'll go now to the osteology of the ulna and that of the radius. So let me go to, so let's look at the forearm. A single bone in the arm. We have one on the medial side. So the one on the lateral side is known as the radius. The one on the medial side is known as the ulna. So if I go to the lower resolution image and I try to separate the two bones, so just to illustrate some points, so that is the radius and this is the ulna. Now if we try to compare the appearance of the two bones, we can see, so let me bring it closer a little bit. So if we try to see the two bones, we can see that the radius on the lateral side is more narrow at the proximal end. So we can see that it is narrow at this proximal end, then becomes broad at distally. It becomes becoming broad and then becomes narrower at the distal portion. So the radius is broader distally, while the ulna is broader proximally. Also, another distinction between the two bones is their orientation. This proximal point of the radius is known as the head of the radius. So this area is the head of the radius, but for the ulna, this area is the head of the ulna, this area. So they are sort of opposite, or they have different orientation. So the head of the radius is up, while the head of the ulna is down. So they are like opposite. It's like sleeping on the same bed, two people sleeping on the same bed, but in different orientation. So one is the head is up, but for the other person the head is down. So we do that a lot, just to maximize the space available. So I guess that's what the ulnar radius are trying to do. No, that's not correct anyway. So that's just to illustrate the point. So for the head and the of the radius and the ulna. So if we look at the radius, so we start our osteology from the radius. So just as we said the head of the radius lies proximally. So the head of the radius is circular. So we can see it is circular. So this is the head of the radius, and it is the articulating surface covered with the hyaline cartilage, and it articulates with the capitulum of the humerus. So articulate with the capitulum of the humerus. So and it's circular, so it can rotate. The radius can rotate freely. In fact, if you rotate your if you feel at the posterior surface here, if you can feel this location, this posterior portion of the head, so if you touch it from your elbow and you try to rotate your hand, you can feel as the radius is rotating in the forearm. As you are rotating your arm, you can actually feel the movement of this head. So let's go back to the anterior surface. So this is the head of the radius, which articulates with the capitulum and also articulates with the ulna. So apart from articulating with the capitulum, it also articulates with the ulna here at this point. So this point is the ulnar joint. So the proximal radio-ulnar joint. So this is the head. So this head is covered by a ligament. So the ligament is called the annular ligament. It is called the annular ligament. So the annular ligament actually articulates with this portion of the ulna at the the head of the radius articulates with this portion of the ulna, also at the proximal radio-ulnar joint. So just below the head, we have this narrow portion known as the neck of the radius, which is known as the neck of the radius. Then just below the neck, we have a tuberosity. And just as we mentioned the other time, when we say tuberosity, we are talking about muscle or ligament attachment. So there's a muscle that attaches to the radial tuberosity here. So that is the biceps brachii. So the biceps brachii doesn't attach to the humerus. The biceps brachii doesn't attach to the humerus. So if I zoom out, remember we mentioned the biceps brachii has two heads. So the short head originates from this knuckle-like projection of the scapula. That's the coracoid process. So it moves down. Then the long head originates from the supraglenoid tubercle of the scapula and moves down. Then both insert into the radial tuberosity. And also, apart from the radial tuberosity, it also attached to the bicipital aponeurosis, which we are not covering today. So it attaches to the radial tuberosity. And because the radius can rotate, so the biceps brachii can rotate the forearm. In fact, any muscle that inserts into the radius can, in theory, rotate the forearm. That is pronation and supination. And the biceps brachii is one of the primary supinator of the forearm. So it's one of the primary supinator of the forearm. So the biceps brachii insert into the radial tuberosity. Then we have the shaft of the radius. Then in the body, these two bones are connected by the interosseous membrane. Interosseous, in between two bones. So the interosseous membrane actually connects the ulna to the radius. Then on the distal side of the radius, we can see it becomes broad. And on the lateral aspect, we have this tiny projection known as the radial styloid process. So we have the radial styloid process, which happens here. And on the inferior surface, we can see the articulating surface of the radius. So the radius actually articulates with the wrist bones. It is the radius that actually articulates with the bones of the wrist. It doesn't have a direct contact with the bones of the wrist, but the ulna attaches to the radius at the wrist joint. So we've talked about the radius. Let's talk about the osteology of the ulna. So let me check if, so just as I mentioned, if there's any question, we can actually we can try to ask in the chat session so that we can answer some of the questions. So if we have any questions, we can ask, so that we'll try to answer any question that is available. So all right, so let's talk about the osteology of the ulna. So the ulna, we said, is broader proximally and becomes narrow as we move distally. So if I try to bring it out, so we can see actually at the distal portion, the ulna looks like a tool, one of these tools. So we can see there's a projection here called the coronoid process, which we've mentioned about, will fit into the coronoid fossa of the humerus during flexion. Then there's a projection here, which is known as the olecranon process, which fits into the olecranon fossa. So in between the two processes, we have a notch, a depression, so we call it the trochlear notch. So the trochlear notch inserts or articulates with the trochlea of the humerus. So it articulates with the trochlea of the humerus. Also, we have the radial notch, which articulates with the head of the radius. So it articulates with the head of the radius at the proximal radioulnar joint. Then if we move just inferiorly from the coronoid process, we have the ulnar tuberosity. And of course, just as we always mention, whenever we hear tuberosity or tubercle, then we think muscle or ligament. So at the ulnar tuberosity, the brachialis muscle inserts. So the brachialis muscle inserts into the ulnar tuberosity. Remember, we said the brachialis muscle originates in between the surfaces of the supracondylar ridge. So between the surfaces here, we have the origin of the brachialis muscle, and it inserts into the ulna. Because it does not insert into the radius, in theory, it cannot rotate the forearm, but it can bend the elbow. In fact, the brachialis is the primary flexor of the elbow joint, so that is primarily responsible for the bending of the elbow joint. So the brachialis muscle is the primary flexor of the elbow joint. So the ulna becomes narrower as we move distally. So now let's talk about some important clinical correlates for yours and the humerus. So the distal end of the humerus here can also fracture. In fact, the medial epicondyle, because it's more prominent, can become fractured and injure the ulnar nerve. But one important fracture we'll talk about here is the fracture of the distal end of radius. The radius functionally, most bones, just as we mentioned for the clavicle, you can roughly divide them into thirds. So we have the superior 1/3, middle 1/3, the distal 1/3 of the radius. The junction between the proximal 2/3 and the distal 1/3, so around this area, so the junction between this area that I'm trying to highlight, so this area I'm highlighting will serve as the proximal, will serve as the distal 1/3 of the radius. So the junction between that proximal 1/3 and the of the distal 1/3, the distal 1/3 and the proximal 2/3 fractures commonly, and it happens most commonly when we fall on our outstretched arm. In fact, it is a natural process for when humans want to fall, or when we want to fall, we try to protect our body from sustaining damage by falling on our hand. So it's a sort of a protective reaction. So when we fall, we try to cushion the fall with our arm. So when you fall on an outstretched arm, that distal radius can fracture. So depending on the displacement of the distal fragment, so we said this distal portion has broken, so there's a fracture around this place. So the distal portion can either be displaced posteriorly, it can move posteriorly, or it can be displaced anteriorly. So if it is displaced posteriorly, which is the most common, the muscles that are located in front, they are generally stronger than the muscles at the back. So if there's going to be displacement, it most commonly happens posteriorly to the posterior surface. So that is what is known as the Colles fracture. That is known as the Colles fracture. So it gives deformity. So it gives a dinner fork deformity appearance. It is known as a Colles fracture. While if the distal fragment moves anteriorly, it is known as a Smith fracture. So a Smith fracture is like the opposite of a Colles fracture. So that's why sometimes it is also called the reverse Colles fracture. So we have the Colles fracture when it displaces posteriorly. Then we have the Smith fracture if it displaces anteriorly. So if the distal portion of the radius displaces anteriorly, it is a Smith fracture. So basically that's the that concludes the osteology of the ulna and radius. And again, if we have any question, we can actually ask in the comment section so that we can try to answer some of these. So now we'll go to the carpal bones. So we are almost done with the osteology. So the carpal bones, they are 8 in number. So let me try to select them and bring them out. So this is the first, second, third, fourth. Sorry, I'm trying to select the 8 carpal bones. The third, the fourth, the fifth, sixth, seventh, and the 8th. So if I try to bring them out, we can see. So these are the 8 carpal bones. So these are the 8 carpal bones. So they make up the bony framework of the wrist. So these are the 8 carpal bones. And it can be, let's go to the lower resolution image to explain so we can see broadly it can be divided into 2 rows. So we have a proximal row, we can see. So these 4 bones here, they are the proximal bones. So this 1, 2, 3, 4. So they make up the bones of the proximal row of the wrist or the carpal bones. While these 4 bones, 1, 2, 3, 4, they are in the distal row. So this 1, 2, 3, 4, they are the distal row, while the 1, 2, 3, 4 are the proximal row. So they are 8 in number, and we'll start. So if we look at roughly it traces a semicircle. If we try to see from here, we can actually try to trace a semicircle. So we can see the wrist bone actually forms a semicircle with the convex area, that is the proximal convexity. It is formed by the proximal row, while the diameter is formed by the distal row. So we'll talk about each carpal bone separately. So this is the scaphoid bone. Let's bring it back to its anatomical position. So we can see this is the scaphoid bone, which is boat shaped. So the scaphoid bone is boat shaped, and it is the largest bone in the proximal row. So it articulates majorly with the radius. In fact, the majority of the wrist joint, that is the radiocarpal, the wrist joint is formed by the radius and the carpal bones, just as it is known as the radiocarpal joint. So the wrist joint, because it is formed between the radius and the scaphoid, it is also known as the radiocarpal joint. So the bulk of that joint is formed by the radius and the scaphoid. Most frequently fractured carpal bone. So if there is a clinical correlate talking about a fracture of the carpal bone, then most commonly it is referring to the scaphoid, because the scaphoid is the carpal bone that is most commonly fractured. And it can also suffer something we call avascular necrosis. Avascular, from the word a means absent in anatomy or medical term. Vascular means vessel. So necrosis means death. So avascular necrosis means death of a tissue because of reduced or lack of blood supply. So avascular necrosis also commonly affects the scaphoid bone in the carpal. In fact, most susceptible area to avascular necrosis because of the blood supply. Now, avascular necrosis affects most commonly the head of the femur in the body, especially in sickle cell patients. But the second bone most commonly affected by avascular necrosis is the scaphoid bone. So the scaphoid bone is the most frequently fractured, and it can also suffer avascular necrosis. Then the second bone in the proximal row is the lunate, which I've just inserted, so we can see. So this is the lunate. So the lunate is like moon shaped. We can see moon shaped. So lunate like lunar. So it also forms part of the radiocarpal joint. We said the scaphoid is the most frequently fractured carpal bone. The lunate, on the other hand, is the most frequently dislocated carpal bone. So it can dislocate anteriorly or posteriorly. So if it dislocates anteriorly, because the median nerve courses into the palm through this place, so the dislocation of the lunate bone can actually cause median nerve entrapment. So it can have the person can have tingling sensation in the palms and the fingers. So after that, we have the triquetrum. So let me bring the triquetrum back to the anatomical position. So this is the triquetrum. So it attaches to the lunate, and it can also form a little part of the radiocarpal joint, especially when there is ulnar deviation of the palm. That is, when the palm moves sideways like this triquetrum contacts with the radius. But the majority of in the anatomical, the radius, the scaphoid, and the lunate. But during ulnar deviation of the finger, of the hand, the triquetrum could also be brought in contact with the radius. But note that in the wrist joint, the bones are never in articulating contact or in articulation with the ulna. Then the last bone in the proximal row of the carpal bone is the pisiform. So this tiny bone, it is the smallest carpal bone. In fact, it is a pisiform bone. So a pisiform bone it is a sesamoid bone. So a sesamoid bone generally lies flexor carpi ulnaris, which comes like this, attaches to the hamate and the base of the first metacarpal. So this bone, the pisiform, lies within the tendon of that muscle, the flexor carpi ulnaris. So it is called, or it's an example of a sesamoid bone. Another example of a sesamoid bone is the patella in the knee. In fact, it is the largest sesamoid bone in the body. So then we go to the distal segment. So as we can see, we said the convexity of the semicircle, as you can see. So this proximal row forms the convexity of that semicircle. So now we now fit in the diameter. So we start from the first bone, the trapezium. So if we bring it back to the anatomical position, so we have the trapezium. So the trapezium articulates with the scaphoid and also to the base of the first metacarpal. So this is the metacarpal. So there's a saddle joint in between the first metacarpal and the trapezium. So then medial to the trapezium, we have the trapezoid. So it can be confusing, trapezium, trapezoid, trapezium, trapezoid. So we'll talk a little bit about that later. Then we have the capitate, which is the largest of the carpal bones. So the capitate is the biggest. Remember, the scaphoid is the biggest in the proximal row, is the most frequently fractured, can suffer vascular necrosis. The lunate is the most frequently dislocated. So the capitate is the biggest of all the carpal bones. It forms like a stable central core of the carpal bones. Then the last of the carpal bone is the hamate. So we can see the hamate. So it has a projection which is labeled, this tiny projection. It is called the hook of hamate, also called the hamulus of hamate. Now, if we look at this hook of hamate and this pisiform bone, we can see there is a valley, there is a depression in between. This depression can be breached by a ligament. Is breached by a ligament called the pisohamate ligament. That is, the ligament moves from the pisiform to the hamate. So it converts that depression into a canal, also called the Guyon's canal. So the Guyon canal, the deep branch of the ulnar nerve passes through this canal and it can become entrapped in that canal. So because the nerve passes through and supplies this little finger and the inner aspect of the ring finger. So if there's an entrapment of the nerve here, there will be tingling sensation in the little finger, just like I'm highlighting, and the inner aspect of the ring finger. So those are the 8 carpal bones. So if we try to summarize them, we have the scaphoid, the lunate, the triquetrum, the pisiform, the trapezium, the trapezoid, the capitate, and the hamate. So to remember the carpal bones, there's a phoneme mnemonics we can use. So you can use some lovers try positions that they can't undo. So some lovers try positions that they can't undo. So some, that would be for the scaphoid. Lovers, that would be for the lunate. Try, that would be for the triquetrum. Positions, that would be pisiform. That would be trapezium. That would be trapezoid. Can't, that would be capitate. Handle, that would be hamate. Now, there might be a bit of confusion between the trapezium and the trapezoid. So what you do is alphabetical order. Trapezium, I comes before trapezoid, O. So if you remove the trapeze, so the I, trapezium, comes before O, trapezoid. So the trapezium comes before the trapezoid. In fact, in anatomy, on the limbs, we like numbering from the lateral side to the inner side. So the scaphoid is taken as the first. We like numbering from the lateral to the medial and from proximal to distal. So if we go like that, that means we have to go from the we have 2 rows, the proximal row, the distal row. So we are starting from the proximal, we are starting from the lateral aspect of the proximal. So the scaphoid, then lunate, then triquetrum, then pisiform. Then we now move to the lateral aspect of the distal row. That will be the trapezium, then trapezoid, capitate, and hamate. Because of that, that's why we number the metacarpals. Metacarpal 1 from the lateral side, the thumb side. In anatomical position, we also made a video on the anatomical position. So the first metacarpal happens to be on the lateral aspect. So the first metacarpal, second, third, fourth, fifth. The same thing with the phalanges or the fingers. So the fingers of the thumb is known as the first finger, while the little finger will be the fifth finger in the anatomical position. So we like numbering from proximal to distal, then from lateral to medial. So the mnemonic again, some lovers try positions that they can't undo: scaphoid lunate, triquetrum pisiform, trapezium, trapezoid, capitate hermit. There are some other mnemonics you can use depending on which one is convenient. There's even one, Sandra loves to pat Tom's two coat hands. There is she loves to pat Tom two coat hands. It depends on anyone which is convenient for you, but me, I find some lovers try positions that they can't undo to be easily relatable and easy to remember. Of course, if we have questions, we can also try to ask in the comment section so that we can try to answer some of them and try to, at the end of the live session, because we soon end, so that we can try to answer some of them. All right, so now we'll go to the metacarpals. So let's go to the metacarpals. So the metacarpals are the bony framework of the palm. We have the first, the second, the third, the fourth, and the fifth. So we number from the lateral side, that's the thumb, to the little finger. So we can see these are the 5 metacarpal. So the first metacarpal is shorter than the other 4 metacarpal, and generally, so I'm trying to use the first metacarpal here as the reference. So we can see it's a long bone, although it's a mini long bone. Of course, more like everybody is a human being, including dwarfs, so they are human. So even if by definition long bones does not necessarily mean they must be long up to certain length, it is based on the structural or the histological makeup of the bone. That's what makes it a long bone. So now the metacarpals are long bones by definition. So it has the base, so the proximal end which attaches to the carpals is known as the base. So this is the base. Then we have the shaft, which is the middle portion. So let me try to highlight that. So this is the base. So this will be the middle portion, also called the shaft. Then this will be the head of the metacarpal. So we have the base, the shaft, and the head. So the first metacarpal is shorter when you compare it to the other it's shorter and more robust than the other metacarpal. And the first metacarpal, just as we said, attaches to the trapezium. So this is a saddle joint. It attaches to the trapezium. And if we look at the orientation of the bones, we can see that the is forward, but the first metacarpal, that's why if your palm, if you open your palm, you can see the direction will come forward. But if you try to flex your thumb, it comes across the palm. So this in essence is what makes gripping position of the bones, even her position of the thumb. So we can try to check out the video on our channel. So because of the orientation of the first metacarpal, it sort of moves across the palm. This is what makes gripping possible. And so mammals and some objects, in fact, there's a saying in anatomy, they say the thumb is equal in function to the other 4 fingers put together. So the thumb in itself is like 4 functions because of the movement and the ability to oppose, because you can bring the thumb to oppose with the second, third, fourth, and the 5th finger, but it will be difficult to oppose the second finger with the little finger. So that is that about the metacarpal. And also the head of the metacarpals can fracture easily. So the head of the metacarpal, both the first the second, third, and the fourth, fifth can fracture easily. In fact, in professional boxers, because when you try to flex your fingers, your knuckles, so it is the head of the metacarpals that will make up the knuckle. So if you punch a hard surface with a knuckle, so there's a chance that you might fracture the head of one of the second to the fourth metacarpal. That's in professional boxers. So in amateur boxers, they can also fracture the fifth metacarpal. So that's why it is called boxers fracture. Then we have the bones of the fingers, which are also miniature long bones. So we call them the phalanges. So the phalanges, or singular, the phalanx. So the fingers, the second finger to the third finger to the fifth finger has 3 phalanges each. You can see the proximal, the middle, and the distal phalanx. So the proximal, the middle, and the distal phalanx. So we have 3 phalanges each in finger second to the fifth. But in the thumb, we have only 2 phalanges, the proximal and the distal phalanges. The proximal phalanx and the distal phalanx. So that makes 14 phalanges in total for the fingers. So they also connect to each other at the interphalangeal joint. Interphalangeal, while the metacarpals are attached to the phalanx at the metacarpophalangeal joint. So basically, this concludes our osteology of the upper limb. We've talked in details about the 32 bones of the upper limb. So we started from the clavicle. So we talked about the clavicle. We talked about the scapula. That's the second bone, the humerus. Then the radius and ulna, making 5 bones. Then we talked about the 8 carpal bones. So that will make 13 bones. So we talk about the 8 carpal bones, that will be 13 bones. Then we talked about the 5 metacarpals. So the 5 metacarpals, that will make 18. Then we talk about the 14 phalanges, that will make 32. So we have 32 bones in each upper limb. So 32 plus 32 will make 64 bones in the upper limb. Remember, we have 206 bones in the human body. So we've talked about the upper limb. So we'll talk about the so we just finished talking about the upper limbs now. Subsequently, we would like to answer some questions about the upper limb in our next live session. So we'll try to talk about some clinical scenarios. We'll bring in some pictures. So I will try to create more like a slide to try and answer some questions, some clinical scenarios, and try to, make it daily activities. For example, if a child falls on the outstretched arm, which type of injury can they have? Then fracture of the clavicle, how can it happen? Then professional techniques, boxers, amateur boxers. Then we also talk about eponyms of some of the fracture. We've actually mentioned some of them today. We talk about the Smith fracture, the Coles fracture, the boxer's fracture. So we also talk about some others in subsequent live session. So I want to thank all of you for joining the live session today. So this is actually our first live session on TikTok. So we hope wonderful. So thank you all for joining the live session today. I really appreciate that, and we hope to bring more educative content. The goal of this channel is actually to educate medical professionals, medical students, enthusiasts, and the general population about the human body. So we are doing so with 3D models. So the 3D models actually has different systems. Most of our videos, we've talked about the cardiovascular systems. So we talked about the we are currently on the skeletal system and the muscles. So subsequently we still talk about the some of the viscera in the body, the nervous system, our sense organs and stuff like that. But currently we are still trying to try to educate us about our skeleton, because the human skeleton is very important. It makes up the bony framework of the body, so it's very, very important. So thank you for joining the live session today. Looking forward to subsequent live. So let me check if there's any question so that we can try to answer that before we leave today. So let me see. All right, so thank you all for joining us.